our agenda is functional neurological disorder. And I particularly think this is really important for us to spend some time considering, because often it can predate or coexist for a person living with multiple sclerosis. And I even think sometimes it can confuse the diagnosis a little bit. So I think us understanding more about it is really important. And I'm really delighted to be able to introduce to you today Dr. Glenn Nielsen, who runs a consultant physiotherapy service over in George's, but he's also got an NIHR grant, which is not easy to get, and he's got one and is leading a multi-centre trial at the moment looking at the effect of physiotherapy. So when he's got the results, he's going to come back. But for now, he's going to share with us ways that we as nurses and physios can support people with FND. Thank you.
Good morning, everyone. I'm really honoured to be speaking to such an important group of clinicians. And also I'd like to say I'm really delighted that FND is a topic of interest in this conference. And I really think that speaks to forward-thinking and holistic care. So thank you very much. Here are my disclosures. And I've been asked to talk about recent advances and future directions in motor FND. So I'm going to start with terminology. There's no other condition that's had quite so many alternative terms over the year. And I think this speaks to our evolving understanding of FND, but probably also our misunderstanding. In recent years, functional neurological disorder has gained traction. It's got its critics, but importantly, it's the patient's preferred term. And the big change just this year is that the DSM released a text revision, and they endorsed the term FND as the primary term. In previous years, it was conversion disorder as the primary term. The ICD, despite a lot of lobbying, has stuck with the term dissociative neurological symptom disorder. And this seems to be deeply unpopular. You don't often see it in clinical practice nor in research. And I think this is a source of clinical coding errors, and then we have an underestimate of prevalence. But whatever you call it, we're talking about neurological symptoms that are experienced as involuntary and they're not better explained by known disease process. I think the message has really finally been received that this is not a diagnosis of exclusion. The diagnosis is based on the clinical examination of the symptoms. So those symptoms must show inconsistency. So what we mean by that really is usually variability. So it's a tremor that changes in frequency and amplitude, or it disappears when the patient's distracted. Or another example might be weakness that you measure on the examination couch that seems to go away when the patient mobilizes. The symptoms should be incongruent with our known functioning of the nervous system. And most importantly, a part of diagnosis is we need to look at positive clinical signs that identifies the patient's symptoms as FND. So these are bedside clinical tests. The most useful is Hoover's sign for positive weakness. Here's Professor John Stone demonstrating Hoover's sign on this lady who has weakness of her right.
Press this heel into the ground as hard as you can. That's normal. And push this heel into the ground as hard as you can. That's weak, okay? And then just lift this knee up for me. Keep it in the air. Stop me from pressing down. Focus on that leg. Really stop me from pressing down. And when we do that, you can feel that the right leg returns to normal. Mm-hmm. Okay, that's good.
So this patient couldn't exert hip extension pressure, but when her other leg was flexed by a reflex mechanism, that extension power returned. So this tells us that this is a disorder of voluntary movement. And then Professor Stone will then explain the diagnosis to the patient using this test as a springboard. I'm making this diagnosis because you have a positive Hoover sign, and that means that. There are many, many positive tests. This publication is quite a definitive list of all the current ones. Some of them have been explained for well over 100 years and described. But the future direction for this work is to validate these tests and develop, sort of get an understanding of their specificity and sensitivity. To date, really only a handful, including Hoover's sign, has good validation. The holy grail of diagnosis is really to find a biomarker that we can use for a lab-based diagnosis. But I think if you speak to most experts, they'll tell you that it's unlikely, at least in our lifetime, that we'll find a lab-based diagnosis that'll be able to compete with very expert clinical assessment. Nonetheless, we do have some lab-based diagnoses. So for tremor, we can look at EMG and find characteristics of that tremor that point towards it being FND. So these are like gaps or pauses in the tremor. They're called tremor studies. There's also a test for functional jerks or functional myoclonus. In this study, they compare EMG and EEG, and they see what's called a pre-movement potential or Bereitschaft potential, which is something seen in functional jerks but not in typical myoclonus. These are quite significant limitations, actually. They can't be used on everybody with these symptoms. But when there are cases of diagnostic uncertainty, and there's plenty, and these tests can be applied, they're really useful to increase that confidence in the diagnosis. So we're seeing them being used more and more. There's some interesting new data on Prognosis. This is a study from the Edinburgh Group, who are really the world leaders in FND research. They followed up 100 patients with functional weakness for 14 years. And what they found was that the weakness had resolved in 20% of patients, but overall quality of life scores didn't change. So most remained symptomatic. A worse outcome was associated with high levels of pain. And I think one of the most interesting things about this data set was that the patients had much higher rate of mortality than what you would expect for their age, at 11%. And the causes of death weren't related to their symptoms or other diagnoses. They were generally lifestyle factors, or cardiovascular causes associated with sedentary lifestyle, and maybe some of the other things that happen in FND, such as high medication use. And so I think this really points us to where we need to be thinking about, which is preventative health measures for this patient group who have symptoms for a very long time. The big question in FND is why? Why did this happen to me? And I think in the past we've been guilty of thinking too simplistically at very simple psychological explanations for functional symptoms. And the data isn't there for a simple, quick explanation. So as an example of this, this paper was released this year and it looked at rates of physical and sexual abuse amongst patients with FND. Roughly 500 patients were included in this data from 3 centers. And here's what they found. Women with FND reported rates of sexual abuse in about a rate of 35%, and men 12%. So this was 2 to 3 times that of neurological controls. It's quite shocking, actually, how common abuse is in healthy people and neurological controls, isn't it? With physical abuse, women were affected 37% of the time and men 28% of the time, so double that of controls. Statistically, it was women for who physical and sexual abuse seemed to have, there was signal in the data that it might be related to the onset of symptoms and the maintenance of symptoms. So there were limitations in this data set, but they did some really interesting analysis, and they did what's called an attributable fraction. And so what they found is that sexual abuse may be responsible for 28% of functional movement disorders in women. Physical abuse, similar amounts. And then they also reported this rather horrifying statistic, which is that on a population level, about 12% of functional movement disorder prevalence in women could theoretically be eliminated if childhood abuse was also eliminated. So, really sobering stuff, but it also tells us that physical and sexual abuse isn't universal in this group. Perhaps it affects a minority. Even if this is a gross sort of underprevalence, not everybody has had abuse. So we do need to think about broader biopsychosocial models for FMD. So when we think about risk factors, we need to acknowledge that there may be physical and sexual abuse either recent to the symptoms or in the past, and it may not necessarily be part of treatment. It might just be one of the risk factors that made somebody vulnerable. Things like personality traits are also relevant, but also one of the strongest risk factors for developing FND or functional symptoms is having a neurological disease. More on that a bit later. Risk factors, again, trauma can be a triggering factor for developing symptoms, but more commonly, our patients tell us about physical precipitating events. So they have an injury, and that led to them becoming paralyzed or developing a tremor. or surgery is a very common precipitating event. Illness is also common, and I think a lot of us are seeing functional motor symptoms that developed after COVID infections. And possibly there's a theory that maybe most, if not all, patients at the time of symptom onset develop or experience dissociation and panic at that time, and that's part of the explanation about why somebody develops FND. More data is needed on that. Of course, we need to think about maintaining factors, and this is a part of our therapy. So this sort of talks about the why. There's another question, which is how. So we believe that our patients aren't making up their symptoms. So there must be a neurobiological mechanism that explains why one patient develops a functional weakness, maybe somebody develops a functional tremor or gait or jerks. And converging lines of evidence are pointing to these predictive brain processing models, so problems with prediction error. Basically, this describes how functional symptoms are a disorder of sensory motor processing, where top-down expectations distort bottom-up somatosensory experiences and motor processing. And the whole system is influenced by excessive attention directed internally. So that's a whole lot of words, and I'm going to try and demonstrate what that means. Firstly, with attention. Functional symptoms require attention to manifest. When that attention is directed away from the body, the symptoms can normalize. So this lady has a tremor affecting her right hand, and as I distract her by getting her to follow me with her left hand, you might see that the tremor in the right stops. When I stop distracting her, the attention automatically goes back to that right hand. Can you see that? So attention is required for functional symptoms. It's probably true across all functional symptoms. It's just easier to demonstrate in tremor. Here's an example of somebody with a functional gait disorder. She's got a staggering gait. The precipitating event for her gait was very painful abdominal surgery, a really painful abdominal wound. She's been walking like this for 2 years now. Watch what happens as she gets to the end and turns the corner. You've got to watch carefully, those steps there. They're quite normal steps, aren't they? So the reason is she's trying to walk, she's trying not to fall, she's actually trying to walk normally, but all of that is just increasing her attention and exacerbating her symptoms. She gets to the end, she's relieved, and she takes 2 automatic steps. Automatic meaning she's not thinking about them. So the other part of and the more sort of complex neuroscience-y part of our explanation is expectation. So expectation relates to patients having a strongly held expectation or belief or prior that their movement will be abnormal. And this is held with such strong precision, and it may not be a consciously reportable thought. And it influences motor output at a pre-conscious level. So one way to demonstrate that is with this video. This lady has a fixed functional dystonia affecting her hand here, and she's receiving botulinum toxin. And maybe she's receiving with a lot of suggestion that it's going to be very, very effective for her. We know botulinum toxin takes several days to have an effect at the neuromuscular junction, but she has an immediate effect. This is a placebo effect, isn't it? Not just a placebo effect, which is a slight increase in therapeutic benefit. This is a curative placebo response. So that demonstrates the role of expectation. She had expectation that it would work. There's some very, very important things to say about this video. Not all patients with functional disorders can have a curative placebo response. It's probably very rare. It's a minority of patients. It's also not an effective treatment, really, in my opinion, for anybody, because the therapeutic benefit doesn't last very long. She'll come back for repeat injections and they'll be less effective or perhaps not effective at all. And then the clinician needs to have an awkward conversation with that patient explaining that actually they had a deceptive treatment. So there are ethical issues here, aren't there? I think it robs the patients of autonomy and the ability to self-manage their condition. But it is complex because our patients want Botox, probably because there's really nothing else for them, and often that's what they're told. This double-blind placebo-controlled trial found that botulinum toxin was no more effective than placebo. Both groups improved. 60% of patients rated their symptoms as improved. And then in an open-label part of the experiment, most patients continued on with having Botox. But importantly, their quality of life measures didn't change with Botox. The next big topic, the future direction of FND, is going to be about interoception. It's where all the buzz is in our sort of neuroscience-y community members. Interoception is our experience of our internal world. It's the word to describe how we know our heart's beating, how we feel pangs of hunger, thirst, or that our bladder is full. This is all part of interoception. And interoception by some is also thought to be at least partly explain how our brain constructs emotion. And there's a growing data set that patients with functional neurological disorders have poor interoceptive accuracy. And perhaps because of this, they're interpreting somatic signals as symptoms. And somehow this whole process relates to the disordered sensory motor processing. So we're going to hear a lot more about interoception in FND, and maybe we might even be seeing treatments aimed at improving interoception accuracy. On finally now to MS and FND. So there's not really a lot written about this, but there's a lot known and discussed about it, isn't there, clinically? There's a lot of clinical wisdom. So again, John Stone's group, they did a systematic review, which was published last year, looking at rates of misdiagnosis. And they spoke eloquently about how misdiagnosis is harmful in either directions. And I don't know if many of you have seen this. I've seen it a couple of times with somebody who's had a diagnosis for several years. And then everybody sort of went, oh, they don't actually have FND. They've probably got so they don't actually have MS, they probably have FND. And then that diagnosis is withdrawn. And what happens to that patient is the really impressive community, the people in this room, the patient community, the charities that really scaffold that person disappears overnight, and it's incredibly traumatic. We need to think about how we do this better, because we probably do quite a lot of it, both in the FND and MS communities. So there's not enough data, but it did find some interesting findings. So FND is quite rarely misdiagnosed. Rates are about 1% to 4% of misdiagnosis, but when it is misdiagnosed, maybe about 10% of those patients actually have MS. But misdiagnosis is probably much more common in the other direction. So a lot of our patients with FND might initially have a diagnosis of MS that's then changed, and maybe it's a bit of a working diagnosis. But it is complicated, as Lou said before. Patients can have both FND and MS, can't they? And sometimes these symptoms emerge at different rates. And also, what is quite well documented is functional symptoms often exist as the prodrome to neurological disease. So patients can have very clear functional symptoms, positive Hoover's sign, no other signs of clinical disease until a couple of years down the track. And it's often things like psychiatric comorbidity or prodromes that lead to that diagnosis. So patients with FND do need to be followed up. And where people with MS are misdiagnosed as having FND, the red herring is usually that they do have a history of psychiatric health problems or mental health problems. And that sort of leads people to that diagnosis of FND. So it reinforces the point that it's a clinical diagnosis based on the symptoms, not on a history of mental health. I said before that neurological disease is a risk factor for having functional symptoms. And here's the data. This is the Scottish Neurological Symptom Study. 3,700 consecutive patients were assessed in outpatient neurology clinics. And they determined that 12% of patients with neurological disease also had functional symptoms. I've highlighted MS there, and it's in line with the other conditions. So there's an important question about how do we address this functional overlay? And it's not always straightforward. It needs to be based on the individual. And in my opinion, this comes down to, does the label FND serve the patient? And sometimes it might not. But I think it will serve the patient if you think that patient would benefit from specific rehabilitation for FND. Maybe they haven't responded to other rehabilitation. Because the treatment for FND differs, the rehab for FND differs from typical neurological symptoms. So that brings us on to treatment. We don't have good data about how we should be triaging our patients to which particular treatments at the moment, nor do we have good data about how to predict who does well. But what we do know is we need a range of treatments to match the heterogeneity of our patient group. And maybe we should be thinking about this in terms of stepped care, where a simple intervention is started with, like a diagnosis. And for some patients, a diagnostic explanation can be enough, and then we can increase the complexity of care as needed. In the UK, we have access to community neuro rehab teams. When I first started working in this area about 10 years ago, many of them would reject referrals, but now most of them will accept FND referrals. Also in the past, mental health teams rejected referrals for this patients because they had physical symptoms, so the patients fell between the gaps. But this is changing, and that's a real welcome change. Clinical psychology and psychiatry is sometimes the first step, particularly when patients have significant psychiatric symptoms like anxiety, depression, maybe PTSD and others that may prevent the patient from engaging in rehab. And of course, we have multidisciplinary rehabilitation. Some of our general neuro rehab units will accept patients now, and as patients become more familiar with the specificity of treatment, we're getting some good outcomes. And there are specialist FND rehab treatment centres. We have one at the National Hospital for Neurology and Neurosurgery, King's, and we have one at St George's in London. Out of London, there's one in Bristol, and there's one in Leeds, and there's a few starting to be formed. These are great centres with really dedicated clinicians, but there's a problem with them. Patients wait at least 2 years, probably, on average, once from diagnosis, before they get there. By the time a patient walks through the door, they've had functional symptoms for 4 years on average, or 5 years. And while they're experiencing symptoms, they're getting worse and harder to get better. So we need to rethink how we do treatment for FND in the UK. In fact, the coming NICE guideline on chronic neurological conditions the team's being formulated at the moment, is going to include FND, and so maybe we'll see some recommendations that might help this. The other thing to think about a treatment is to treat comorbidity. Almost all patients have other health problems. These is part of the risk factors for why they developed FND. And so often they're overlooked because of the florid nature of their other symptoms. But sometimes if you treat pain, migraine, or sleep apnea, which I see a lot, they're the things that's driving the functional symptoms, and the functional symptoms significantly improve and sometimes resolve. So these patients do sometimes have a rough ride because their other problems are overlooked. Education is the basis, it's the cornerstone of treatment. There's very good online information from neurosymptoms.org. And this was tested in a randomized controlled trial, which showed that the patients valued the treatment, but online education isn't treatment enough. It's just the start. Really welcome change has been the publication of consensus recommendations for treatment. So we have recommendations for physiotherapy, occupational therapy, and speech and language therapy. These are open access, and they describe really practical treatment strategies, fun treatment strategies that everyone in this room can try out with their patient if they have a symptom. So I'd encourage you to have a look at them. They also explain what it is about rehab for FND that's different from other neurological conditions. And the main thing to think about is typical neuro rehab may get the patient to think about their symptom and then to try and change it. But we know that that attention exacerbates functional symptoms. So the strategies described in these papers are novel ways to try and redirect the patient's attention away from their symptoms to get movement to happen automatically. Of course, education and teaching patients self-management strategies is a big part. I'm going to show you some videos of sort of how we might do this. So this patient, you might see, has functional dystonic posturing. We've asked him to stand up here. And he's not got a normal sit to stand, has he? He's using his arms. He's probably afraid to fall, and he just can't initiate the movement properly. When he sits down, he's not lowering himself with his legs. What he's doing is just lowering himself with his arms. And he's sort of stuck. Now, this is the same long session, and it's not a perfect sit to stand, but it's a work in progress. And it's all in the same session. So these strategies of automatic movement, the ones that helped this, firstly, he's looking at his movement in a mirror. You might think, does that not increase attention? But what it does, I think, is it changes this attention from the internal sensory state to the reflection on the mirror, externalizes it. And he's in a very safe environment, so he can sort of start to bring himself forward. So an important part of sit to stand is that translation of the trunk to use momentum. Using momentum automatically switches on his tibialis anterior, and it switches off some of those muscles here that are causing the dystonic by reciprocal inhibition, and so we start with repetitions to normalize his posture. And the other important thing is repetition, repetition, repetition. Perhaps what we're doing is we're redirecting his attention and we're giving him an experience of normal movement. So maybe we're changing his expectation, addressing those two important mechanisms. This is a bouncing or bobbing gait. It's quite a common type of functional gait disorder, and we don't really see this in other neurological conditions, so it's considered a positive sign for functional symptoms when it exists alongside other symptoms. And here are some ways that we might address that. We're getting her to weight shift from side to side. So we're using automatic movement. If I ask her to stand straight, it'll direct her attention to the movement and the opposite will happen. But with rhythmical weight shift, it's a bit more automatic. She's using the mirror. If I ask her to take a step, it'll be a dystonic step, but I get her to creep forward using weight shift. So she's initiating stepping through weight shift, not thinking about it. You saw this lady earlier. These are some of the treatment strategies that she practiced. So automatic movement, dancing type movement, rhythm, and she entered our 5-day intensive rehab program and had a really good outcome. She's a committed member to our PPI in all of our research, and it's really great to see her doing well. Does this work and does it lead to a sustained benefit? It's a really good question, and it's one that we've been working to try and answer, and others. 2016, we published this randomized feasibility study, so we compared specialist intensive 5-day physiotherapy to standard community neurophysiotherapy. The type of physiotherapy maybe someone with MS might have. And we found a significant outcome in a range of outcome measures. This is the EQ5D, a physical and quality of life measure, which showed a big treatment change and maybe a little bit of cutting off at 6 months. But we saw enough here to think we're going to test it in a randomized controlled trial, which is what we're doing at the moment. The intervention is delivered over 3 consecutive weeks, and it's compared to community neuro rehab. We have 12 sites around the UK. We recruited 355 patients. We had a little bit of a hiccup with COVID, but we're back on track. We're in the final phase of the 12-month follow-up, which we'll have in March next year, and shortly after that, I'll be able to tell you if we have a statistically significant result. Just to finish up, I'd like to highlight that there are some very, very good patient organizations, charities run by patients. These charities collaborate very well with clinicians and researchers and the big names in the field. So when you look at their website, overall they give very useful information. But also community is really, really important. This is a group that describe themselves, rightly so, as feeling very medically isolated because they're often told there's no treatment for them. And these services offer community. And lastly, there's now the Functional Neurological Symptom Disorder Society, an international society. Our last meeting was this year in Boston. There'll be a meeting in Italy in 2 years' time. I'd really encourage you, if you have an interest in this area, to join. It's relatively inexpensive, and it's a fascinating discussion to be part of. So with that, I'd like to thank my mentors and people who I work with, and thank you very much for listening to me.